It is my pleasure to introduce once again a good friend and colleague of many years and a very faithful member of our mental health task force around the Carter Center as a key advisor through so many different activities through the years. Larke Huang.
Thanks very much, Tom, and welcome all of you to the third panel. Our third panel is on developing leaders for tomorrow. I want to thank Tom and John Bartlett for inviting me to be part of this program. And again, to give kudos, as many people have here already, to Mrs. Carter for her really tireless, relentless, persistent championing and leadership in the mental health and behavioral health arena. I've been involved with the Carter Center Mental Health Task Force now for probably just under 14 years. I came aboard around 2000, and it's really been an honor to work on that task force and a tremendous learning opportunity for me in conjunction with the other people who serve on that task force. I work at SAMHSA with the federal government. For those of you who don't, most people who know who SAMHSA is here, I think. I work in the Administrator's Office of Policy Planning and Innovation. We have increasingly in recent years had more restrictions on what we can do at SAMHSA, restrictions on our traveling, restrictions on our funding, not always having a budget to even do programming with. So as a consequence, our travel has been restricted. I haven't been here for the last couple of Symposium. So when I arrived here yesterday, it was very much like a grand reunion of seeing people I hadn't seen in a number of years, seeing people who I hadn't seen in 5, 10, maybe 15 years, coming together with embraces, hugs, catching up over the last 10 years. And listening to the speakers, it also was very exciting to see where they are now and hear many of them saying, well, 30 years ago, I was working on this, or, you know, we started about 25, 30 years ago, Ron and I, or Howard and I, or something. And then we heard the 4 very entertaining, marvelously entertaining anecdotes from 4 of the leaders at the Mental Health Carter Center Mental Health Program last night. And in Kathy Cade's words, these were the men behind the successful women. And as I looked around at dinner last night, and as I looked around at our room here yesterday, I was impressed with the amount of wisdom, the amount of experience, the amount of institutional knowledge, really deep knowledge, and the giants in this room in this field, in mental health, and then increasingly moving to also be inclusive of substance use. But what I kind of wondered was, where are our future leaders? You know, where are the people that we want to be here standing on the giants, like you all sitting out here, to take us into the next 30 years? I was thinking, where are the young, bold thinkers, the Google-type thinkers, that are trying to solve the problem that Dr. Ray Fabius put on the board about the inevitability of death? Well, there is a now unit at Google that's taking on death. You know, where are the people who are developing vertical GPS? Have you heard of vertical GPS? So that was just in the papers yesterday. Vertical GPS is, you can track people by their cell phones to anywhere in the area or any buildings. But now you can actually track what floor they are on in the building, because we can do vertical GPS. You can probably track whether they're sitting or standing now as well. So let's try to think about, where are these thinkers that are moving fields in different ways, dramatically, quickly, dramatically making changes in how we live our lives. You know, where are the kinds of thinkers that we need to think about in our own field around that? So I think we need to think, how do we use these new concepts, use this new technology? My kids are always talking to me about a shared economy. I say, I'm not sure I can trust Google Uber cab or an Airbnb, and they said, that's the way of the life, Mom. That's what we're doing now, shared economy. How do we bring those kinds of building on each other's skills and competencies into our field? I reviewed the abstracts and the key themes and memorable moments from the past 29 symposium that were compiled by the Carter Center Mental Health program staff. And it was a very cogent articulation of the themes of the times, of the issues of each of those years, and a lot of good anticipation of issues to come. One of the topics that was a bit absent, not directly hit upon in any of those symposium, was the issue of what we've talked about, in particular in the last panel, of human capital, of workforce development, peripherally, but not head-on in those symposium. There wasn't also any outrage at the loss of federal funding or training funds, which trained many of us as we went into this field by federal government foundations, certainly the federal government, although federal government invests tremendously in medical residency training, millions and billions of dollars. We don't see that in our field. So what we need to think about is what will the workforce of tomorrow look like? Where are our leaders? What will they look like? How will they incorporate new technology, evolving science into the work that they do? And also, as we hear about integration, which was just an excellent panel, the one preceding this, how do we more broadly, and I like Ben Druss's concept of what do we really mean by integration and what are we going to look like post-integration? I want to just give an example of integration that doesn't have to do with primary care. We need to think about how we're also integrating our behavioral health knowledge, information, skills, and training into non-health fields. Let me give you an example out of the children's world, because we haven't heard a lot about children. We worked with the federal agency that oversees the early care and education program. That's child care, early Head Start programs, preschool programs. They are funded by a block grant, the Child Care Development Block Grant, that just got a new reauthorization language and a new, just passed just earlier this week. And this is a $5 to $7 billion grant. It's a steady source of funds. The number one issue for children in early care and education is mental and behavioral health issues. We see expulsion rates of young children, preschoolers, toddlers, from daycares and preschools at a rate that's higher than our expulsion rate for youth in K through 12 programs. So this is of major concern. We worked with them on the language, so now in the reauthorization language, there is attention to social emotional development and the need for mental health consultation. So we also look at that in a way, it's not exactly the integration we were talking about previously, but it's also identifying other host systems we need to think about that have their own steady streams and funding to think about how we can get our behavioral health interventions technology into those service systems. I want to just give you a few slides just about some of the data issues, which gives a compelling issue for why we need to think about the workforce. How do we grow the workforce? What is the nature and quality of the workforce? This comes from SAMHSA's data. We do an annual survey of mental health and substance use issues across the nation. It is a household survey. Respondents, about 77,000 respondents per year, and it does follow a national sampling frame, representative sampling frame, so we can do estimates of mental health and substance use issues. So in this slide, and I apologize for how busy this slide is, we are very restricted in our traveling, restricted in our funding, restricted in our program, so we go wild with our slides and our data. So I actually took out some of the stuff the staff had put on that single slide, but what it says is that 1 in 12 adults have a substance use disorder. It's about 20.3 million people. 1 in 10 adults use illicit drugs, 22.4 million people. And we saw the binge drinking risk on Dr. Ray's slides earlier. 1 in 4 adults in the U.S. engage in binge drinking. That's all on the substance use side. If we look at the mental health side, about 1 in 5, and this is just, we do the survey looking from age 12 and up. I'm just giving you the data for the 18 and up. 1 in 5 U.S. adults had any mental health any mental health illness. That's about 43.8 million people. Of those, about 10 have a serious mental illness. That's an incapacitating in at least one domain of their functioning in their lives. That's 10 million. And we also heard Mark from Dartmouth talking about the co-occurring disorders. About 7.7 million people this country present with a co-occurring mental health and substance use disorder. So you think of that and you think about we're not able to treat nearly half, even close to half, of the people who meet criteria for these disorders. What are we doing in terms of a workforce? Okay, so we have the Affordable Care Act. We have now 10 million newly insured individuals. This act will provide insurance to millions previously uninsured and also cover behavioral health treatments. And importantly, as we move upstream, some of the preventive screenings such as risky alcohol use and depression. But we see an increased need for a more well-prepared health workforce. If we're going to move upstream, we also have to create not just providers who are treating the issues and moving people to recovery, but also preventionists. Who are the people who are going to do some of the upstream work? And we need to look at the increased need for behavioral health practitioners. We are beginning to look at some of this in terming it access deserts. While people may now have access to coverage, it doesn't mean they have access to a provider or to an appropriate practitioner. Okay, I'm getting the sign to move on here. I wanted to just tell you in terms of uninsured, these are within the uninsured, these are the rates of percentage of uninsured with serious mental illness and substance use disorders for people 18 to 34 and for those 35 and over. So we see a huge growing and continuing to growing need for mental health and substance use prevention, treatment, services, supports, and recovery. We see also a need for tremendous diversity, increased diversity in our workforce, and we haven't talked about that a lot here. We see a high prevalence of substance abuse and mental health issues among the uninsured. Over 50% of the uninsured are people of color, people with limited English proficiency. So we know that we need to have an increased diversity of a workforce that can provide services to that particular population, which we hope will get increasing opportunities for coverage. So critically around the workforce, absolute numbers are starkly limited. The quality we need to look at, the retooling coming out of education, out of training, and what the issues are that they're going to be confronting in the context of care delivery, and the diversity of the workforce. Okay, so we have a panel, an excellent panel, that's going to address some of these issues. I'm going to introduce them to you quickly. You have their bios. We're going to start with Dr. Peter Buckley, who is a psychiatrist who trained in Ireland. He's a dean of the medical school at the Medical College of Georgia and interim CEO of Georgia Regents Hospital and a physician in practice plan at the Georgia Regents University in Augusta, Georgia, and he's also done ongoing clinical research in the area of schizophrenia. And he will share with you some relatively stark data about what the behavioral health workforce looks like. I'm going to introduce everybody first, Peter. And then Ms. Sue Bergeson is the Vice President of Consumer and Family Affairs for Optum Health, the behavioral health arm of United Healthcare. And Sue has done some very innovative work around expanding the roles of consumers and peers. And then finally, Dr. April Foreman is a licensed psychologist who, in her words, her mission is to inspire and build a mental health system designed for people with severe and sometimes lethal emotional pain and really incorporate the use of technology. And I guarantee you're going to get some compelling and provocative presentations from our panelists. So let's welcome Dr. Peter Buckley first.
Good morning, everybody. It's a terrific pleasure to be here. Ben, congratulations on the last session. That was absolutely terrific. And also, thank you, John, and thank you, Tom, for the privilege of being here. And Mrs. Carter, thank you for your lifelong advocacy on behalf of mental health. It's been extraordinary. Thank you. I have the opportunity to talk about workforce development, and over the next 2.5 hours of my presentation, don't worry, I'm going to cover a fair amount of ground, and unfortunately because of it I'm going to give a ineffective presentation. The area is quite broad. In thanking people that gave me the opportunity to be here, I should also recognize my mentor who gave me a job when I needed one in Case Western Reserve, Dr. Mike Hogan, who worked for Ohio Department of Mental Health, and so I feel very privileged to count Mike as a mentor along the way. And I thought I would proposition this in the context of a movie well known, and also give you the sense that there is good news, there's bad news, and there's some in-between news. And I've also been told to stay on time, so I could do this really easy and just say we need more, and I could sit down. But the question becomes more of what and more of where. So what I'm going to try to do briefly is review at least my understanding of the current workforce, how healthcare changes will shift that, and we've heard some of that already, so I'll try to build on that, and then what are the obstacles as well as opportunities, and then end up with some blue skies opportunities that themselves could radically change the workforce for mental health. And you hardly needed to come here today to know that not only is the array of personnel that provide mental health care very broad, from informal and colloquial through to highly specialized, but it simply is not enough. And it continues to be not enough. In fact, it's growing not enough. And so if you look in our own backyard and look at some figures for our own mental health system in Georgia, we continue to have gaps in personnel. And then, of course, many states, but particularly Georgia, is a more populous state in its corrections facilities. And there was an even stark disparity in the lack of personnel to treat people with mental illness. This gives you some information with respect to a snapshot of what the number of different personnel are in the, per estimates, 100,000 of the US population. Healthcare is a good field to go into. It's not going away, and by all statistics, neither is mental health, and you heard more of that this morning. But when you look at the actual spread of personnel, it's rather meager when you compare other primary care specialties. And then when you drop down into Georgia itself, unfortunately, we distinguish ourselves by not only not having enough doctors in a rural state and mental health providers in a rural state, but we simply don't have enough mental health providers in general. That is equally in stark context with some of the information that you've already heard earlier this morning from Ben and from Dr. McGovern, that indicate that whether you look more narrowly in mental health or whether you broaden the lens and include addiction and the portfolio between, or whether you wander over to physical health, as we just heard in the last presentation, they're all inextricably linked, and mental health is in many ways the linkage. And so the rates of mental health are really, when you look very broadly, are quite staggering, and hence the great disparity. They're also staggering from an economic point of view, and Dr. Scharfstein and others in their time commissioned the Millman report commissioned by the American Psychiatric Association to look at what might be the economic impact of parity if we could get a handle on services provision, particularly inpatient provision, for either either substance abuse problems, mental health problems, or the combination thereof. And the figures are very staggering, whether you look either in the federal pocket of Medicare or Medicaid, or whether you look entirely to a potential savings of $293 billion by adequate care of people with mental health. And currently there is an initiative to try to make sure that as the UN propagates its next focus on health living, that mental health and mental health parity is not only in the running, but is also resourced in a way that could provide the kind of health care as well as the health care personnel that are needed. Now, that is all well and good, but of course it starts back at the classroom and also at the pipeline. And so just some words about what's happening in terms of education that will shape the individuals that will go into mental health and also shape both their values and their competency. And Larke mentioned in her opening remarks that we are a technological savvy, Google-driven environment. And that, of course, has enormous implications for healthcare provision, as well as potentially the detection and early prevention of healthcare. And I'll say a little bit about that along the way. We've also changed our health and education models. We're not simply relying on the bedside, but we are trying to bring our research closer to the bedside in terms of practical implications of research. And then also we are using models of care and models of education that are new, that include things like standardized patients, virtual patients, and these are being used to evaluate things even like empathy. How do we train young doctors and psychologists for empathy? Well, it turns out you can use a computer to help that. We have curricular changes. Gladly, if you go to medical school now compared to a number of years ago, the MCAT, the entrance scores, have changed to include greater emphasis on social, behavioral, and mental health components. And so this is a good thing for all doctors in training. There are other changes, of course, as medicine gets increasingly sophisticated technologically, as well as with genetic breakthroughs, and these prime the pump both for interest in medicine, and then specifically, depending on where psychiatry lies, interest in behavioral health. We are moving away from training professionals in silos, and there is a great effort towards interprofessional learning, and this is perhaps one of the areas where mental health professionals are a little bit better, because we tend to talk to each other and we tend to train and learn from each other, and so this is an opportunity for us. There are issues of professionalism, issues of compassion, and we heard earlier that quality is becoming the corner of the coin of the realm in terms of population health and in terms of healthcare delivery. And this is a very, very great issue for the field of psychiatry, which quite frankly is a little late to the game. Larke presaged the remarks in terms of the style of today's and tomorrow's healthcare providers, and they are millennials and beyond, and they neither have the regulatory capacity nor, quite frankly, the interest to be working 80 hours a week. They're savvy citizens, and they want to touch information quickly, not have it in their head, but acquire it quickly, use it quickly, and balance their life. And that has huge implications for our healthcare provision. I wanted to say a couple of remarks drilling down on some of the main healthcare providers. You may notice, you could hardly not notice, it's hard to see a child psychiatrist. It's not because they don't want to treat people, there simply just are not enough child psychiatrists. And so we have a production problem in the field of child psychiatry. We also have some splits that don't serve us well, and you heard that in the other presentation in terms of service delivery, but of course it also impinges on workforce development, and we have dichotomies, kind of blocks, divergence in the road between becoming an addiction specialist or a psychiatrist, and then whether you practice in the public system, the private system, or whether you become a hospitalist, if you like, a consultation liaison specialist. And quite frankly, we haven't figured out what's the right distribution and proportion of all of these. We have a pipeline challenge. Only 4% of medical students go into psychiatry. And unfortunately, that is a fairly consistent statistic year in, year out. And even though we've seen this year a 4% increase in the number of applicants to medical school, and we've increased the number of medical students by 30% in the last number of years, psychiatry is staying flat at 4%. And we also have an overrepresentation of international medical graduates. I happen to be one of those, but it may not be the best in terms of cultural sensitivity and development and congruence with the population served, as Larke indicated in her opening remarks. And stigma is, of course, a unfortunately unifying theme in mental health, but it is also a turn-off for kids that are going to try to decide what field they're going to go into. Money also matters, and psychiatrists get paid less than other specialties, and that is an issue because doctors coming out of training are lumped with a 150 to 200K loan repayment debt that does influence what they go into, and so it's another factor for us. We also have issues in terms of what we're training for, whether it's integrated care into professional care, and as I mentioned, the need to really gear up for quality and best practices in our field. And then we have another large schism as to whether we should train more psychiatrists or simply train primary care doctors better and reach down into the population for population health. The psychologist workforce is even more diverse because the field is very varied and spans all the way from counseling to occupational health with subspecialties in between. Again, Georgia is underrepresented, and then we have workforce concerns in terms of how do you develop the core competencies if you have a generalist training. That does not provide you with the competencies to be an occupational health psychologist as opposed to a forensic psychiatrist or psychologist. We have issues also around salary and payment. We have parity issues, and then we're dogged by a certain recurrent issue with respect to prescribing practices. And we have an opportunity to grow our own, and our medical school has been fortunate to have a grant from HRSA and to work with Georgia's Department of Mental Health, and we've brought training psychologists into Georgia, and more have stayed and left, and more have gone into the public system. And so that's an opportunity for us, of course, across the country. Nursing shortages are even more dramatic, and they are dramatic as a specialty, not just behavioral health nurses. They are dramatic as a specialty. In our own state, we predicted 37,000 shortage, fall short within a number of years in nurses, and also the nurses, both in practice and that trained nurses, are an older workforce disproportionately compared to other groups. And so we have an aging workforce of nurses with fewer nurses entering into the workforce, and psychiatry gets the short end of the stick in nursing, and we have also not figured out how best to integrate advanced psychiatric nurses. A number of years ago, Mike Hogan presented the findings of the President's New Freedom Commission at this meeting, and Mrs. Carter stood up and said that the single most difference between the original document and the second document that Mike and colleagues produced was the notion of recovery. And that, of course, had helped span a workforce that is an important workforce. But I show you some data from within Georgia looking at the activities of peer support specialists within our own state. And it's a kind of mixed bag. People are underpaid. People are not in as much work as they've been trained to be. And then, of course, work itself builds resilience, and people that are peer support specialists relapse as well. And so it's a complicated workforce to develop, but a very important one, and I'm proud that Georgia has taken the lead nationally in that area. As I come to conclusion, some broad remarks. First of all, John, I was grateful to you for sending me this article. This is a proceedings of a primary care summit that, if you scratch out primary care and put mental health, it's extraordinarily apt, because all of the issues in terms of context, in terms of teamwork, in terms of integration, and in terms of measuring results are extraordinarily relevant to the issues of workforce development. So we have issues to work on with respect to pipeline, to encourage young people to get excited by mental health issues and societal's interest in mental health. We have to create the right kind of programs, and we have to develop the right pipeline, both across the board, but then also specifically in individual guild areas. And then we need to support specialization in areas that appear to us to be more prominent, and they include addictions, they include correctional psychiatry and psychology, and, as I mentioned, child psychiatry. I mentioned at the beginning that there are a number of things that could change how we provide care, and of course mobile technology and social media is a good example, and it can change for good and for bad. We've seen individuals under greater stress and exposure of their symptoms on social media. And then equally, we've seen programs, particularly in Australia, that use social media as a gateway towards mental illness and beautifully bypassing stigma. And so we have great opportunity, and that will influence not only the volume of people needing mental health, but also potentially the types of mental health. We've heard earlier about collaborative care, and that is a model that is effective not just for depression, but also for a variety of things summarized in this important meta-analysis, and that has, again, another example of where things could change radically. The insert in this slide is Kevin Buchberger from Cleveland, who was down and out and homeless and in and out of jail, and he got on clozapine, and it totally changed his life. And it also emptied out state hospitals all across the state, and so all across the country. And so the story of drugs and what they can do is always a potential game changer, and we've seen that in our field, and that holds out hope for us. We heard earlier about the potential of telemedicine, which is long and enduring, but it'll never reach its full potential if we don't figure out how to pay for that. Biomarkers for mental illness are a very hot topic with the National Institute of Mental Health. We are building our treatments and our understanding on the quicksands of symptoms, and we need to understand the fundamental structure of mental illnesses behind that. Genetics is the most obvious example of that, but genetics can also, just like cancer, pave the way to personalized medicine, where you can determine the genetic makeup and then make treatment decisions based on that. And that is a brave new world and future that we're certainly not there, but that holds opportunity. And then cognitive remediation, a little closer to our field, is another potential game changer. Imagine somebody with schizophrenia could potentially be giving themselves treatment at home while they're exercising. They could also be exercising their brain, and imagine the impact of that for treatments, and there are many others. So let me conclude my remarks by reminding you this was a miserable presentation, in part because it's an extraordinarily broad area. I do believe we have a rudimentary pipeline compared to other specialties, and this is important for us to wake up and see that. We have deficits not in one area, but across the board, and we are to a certain extent hamstrung by our siloism, by compartmentalization, and also by an inability to see and fund and resource and advocate for the total picture of mental health. Having said that, mental health, as all of you know, is not only extraordinarily tragic, it is also pervasively interesting, whether you take a sociological perspective, whether you take a psychological and neurobiological or a recovery perspective. There is enduring public interest in mental health, and so for mental health, it is always the decade of the brain, and I believe I'm on time, and I will stop, Larke. Thank you very much.
Thank you very much, Peter. I might take issue with that being a failed presentation. I think it was a great tease for your next 2.5-hour lecture. So packed a lot of information into that. I'd like to bring up Sue Bergeson now, who's going to talk to us about another aspect of the workforce and the innovative and leadership work she's done around peer specialists and peer support.
Thank you. So, this is really cool, just saying. I'd like to thank the Carter Center and Mrs. Carter especially, and thank you, Dr. Borneman and Dr. Bartlett. I'm really honored to be here. And I know many of you have been up here at one time or another, but my hope is that each one of you get this experience because it's very exciting and very terrifying. Just saying. So I've been asked to talk about the expanding role of consumers, touch a little bit about the history, touch a little bit about the future, and a little bit about the obstacles that we might be facing. So I'm going to start with the same kind of overview that you might have heard, but from kind of an opportunistic spin. So we might be in the perfect storm as far as the behavioral health workforce goes. We've got the influx of newly insured. The data that I keep seeing from SAMHSA is an aging out of the psychiatrist and psychologist population. We've got few people entering. We've also got new models that we're all trying to figure out, which creates an opportunity for new staffing structures and new ways of thinking about delivering the services that we're offering and whole new services that we're offering. We're embracing this recovery and resiliency and person-centered focus, which means we have to do business differently, which again is a great opportunity for thinking about new models of staffing. We've got the CMS triple aim, which I know we each have tattooed above our heart, correct? I always think about that in 3 words: quality, effectiveness, and cost. We've got new states and counties, managed care organizations all embracing peer support and the role that peers who are in recovery can bring to the table, the things that we can do. So in some ways, this perfect storm in the behavioral health workforce has opened the door for peer support services to flourish. So I'm asked to talk a little bit about the history, and I could do some really interesting things because the history of the peer movement is particularly rich and very exciting. But instead, I want to talk about the history of the workforce in the last 30 years by using a couple stories. And here we have Pat Deegan. If you don't know Pat at the top, Pat is one of the heroes in the consumer movement. She's given me permission to tell this part of her story, which she's certainly written about quite often. And you know, Pat was hospitalized in high school for the onset of her schizophrenia diagnosis. And when she was in the hospital for a really long time, here's what they told her that she could look for. Her job in the future, if she was very, very good and very, very compliant, would be that she could be entrusted to clean the bathrooms in the state hospital where she was hospitalized, and she would never be leaving that state hospital. Now it's 30 years later. Pat Deegan has her PhD in psychology. She consults with states, with countries like Scotland and Australia and New Zealand, and she's got her own business in the tech world where she's designed award-winning products that use technology to enhance participatory design and to enhance consumer activation and self-care. Right there, you got 30 years. Here's what my hope was, cleaning the bathrooms, and here's what my reality in the workforce is, running an award-winning small business. Do we need to say any more? about the movement of peers? Okay, we also have other heroes up here. We've got Paolo DeVecchio, who is the head of the Center for Mental Health Services in SAMHSA, a lifelong consumer who's been active in the movement. We've got the great Karis Myrick, who is with us today, who has run the most amazing nonprofit organization, so good at it. Now she's a new part of the Center for Mental Health Services at SAMHSA. Your title, Karis, is Director of Consumer Affairs, is that right? The other thing that I find amazing about Karis is that she was the first, I believe this is correct, first identified consumer as the board chair of NAMI, not just a consumer and provider together, but a consumer. Second. Okay, well, she's the second. And you know, it wasn't that long ago that NAMI had a real problem with figuring out if they would allow peers at the table if they were willing to work with us and not just on us. So that is a real movement forward in the past 30 years. We've got the great Larry Fricks here from Georgia, who, as you know, has done tremendous innovation, creating the first Medicaid reimbursable peer specialist programs, creating the whole health action management program that Linda's National Council and the TA Center, SAMHSA HRSA TA Center for Integrated Care are using across the country. We've got peers who are researchers. Here you have Jean Campbell, who led the multi-million-dollar SAMHSA research project on the value of peer-delivered services. And there you have Peter Ashenden. And you might recall, if you were here last year, Peter spoke a bit, and Peter works for me, and he is a director in a Fortune 13 business. So we might say, what's the emerging role of peers in leadership? But the reality is, peers are leading now. It's not a future state. Peter was told 30 years ago that the best he could expect was that he would spend his life putting the caps on lipstick tubes. That would be his life. 30 years later, he's a director in a Fortune 13 company. That is the history of the peer movement in workforce. I have one more picture to show you that gives you that 30-year viewpoint. So 10 years ago, we had 2 states who were working on peer specialist training. And if you look closely, you will see that you'll see Arizona and you'll see Alabama. It should be Georgia. I'm very sorry. I know, hiss, boo, boo. Didn't check that super carefully when I got it back from the tech people. So 2 years ago, 2 states. Now, 10 years later, everybody but 3 states are engaged in training and certification. There is the history of the peer workforce movement. Okay, so what are peers doing out there? Since I'm in managed care, I'm going to start with what are peers doing in managed care. We've got peers who are working at the national level, the state, the county, and the region level. We've got peers working as specialists, as supervisors, as managers, as directors, and as vice presidents. We're throughout the entire system. Peers are also working as coaches, peer and family coaches, both in mental health and recovery services. They're working as facility staff. We've got people doing welcome and orientation to new facilities. We've got people doing intake coordination, recovery planning, advanced directive work, activation and self-care, which I think is critical, and community resource connection. We've got the traditional roles that people are doing, working support groups and doing teaching and training. And I would highlight 2 things here, since I know we have people in the house. We've got mutual support groups like DBSA. DBSA is here today, and Mental Health America, who have done that. And you cannot overestimate the importance of these free support groups throughout the community. The research is clear. And they're doing this completely free and reliant on the support that we can give them. And we have Mental Health First Aid that Linda has already talked about through the National Council, and peers are leading these sessions all across the country. It makes an incredibly powerful experience. Talk about reducing stigma. When your instructor for Mental Health First Aid can say, yes, when I went into my first psychosis, and they're a completely wonderful, normal person, you reduce stigma like that. And then we have peers doing all sorts of interesting other things out there. We've got people running a warm line. If you don't know what a warm line is, it's an 800 number you can call when you don't need quite yet a suicide hotline. But you're panicking, you're thinking the ER, you're wondering what to do, and you can talk to a peer who's in recovery who can remind you of your strengths and give you tools and resources like yoga breathing and gratitude journaling that you can do now so that you have time to get back to yourself. We've got people doing smoking cessation and weight loss programs. We've got people working in prisons and jails. We've got online support groups, peer-run and engaged crisis respite, supportive housing, and of course we've got peers working in state and national administration. We've also got people who are non-behavioral health who are working in peer positions. We have the emergence of the community health workers, the promotores out there, and we've got peers working in cancer, we've got peers working in HIV/AIDS and in COPD. So it is an emerging movement. Okay, so I want to give you one specific example about the impact a peer can have when they're brought into our systems. And since I'm from Optum, I have Optum data, and I'm going to give you an Optum example. So in one contract that we had, we worked with the customer, in this case a county, and said, let's redesign your crisis response crisis response system. And what we did was we just embedded peers in every part of it, and we added more peers and more peers until every single aspect of this program has peer involvement. So we've got the warm line running there, we've got the crisis line, and what we're doing is we're training professionals. Peers are training professionals, reminding them of the lived experience, how to talk to us, how to interact with us, so that we'll hear what you say. We've got the crisis response team, and instead of one peer on the team, we've got a whole host of peers that can be called, so that people speak different languages, people have different ethnic backgrounds, people have different genders and different age, so we can get as close as possible to someone who looks and feels and is a little bit like the person in crisis. We're doing, of course, police CIT training, crisis intervention training, and we're using peers to do that training. We've implemented the Living Room and Recovery Response Center that was originally developed by Recovery Innovations, and 50% of that team are peers. Peers are the first people to see them, and what do they do first? They remind the peer of their strengths, and they help them think about what is it you want, what's your recovery goal here. Start with the person. They stay 3 hours, they stay 3 days. If they stay more than 3 days, they need to be transferred, if needed, into the mental health hospital. We are able to reduce the involuntary commitment and keep people activated in their own care by making the decision to go into the hospital. So consumers really love this, and the piece that's not up on this slide is we have peers assigned to the post-living room, post-recovery response center, or post-hospitalization follow-up. They stay with people 3 to 5 weeks. They help them access community resources. They make sure that they have appointments to see their docs. They put in their hands activation tools like wellness recovery action planning, remind them of their strengths. They stay with them until they're able to completely move comfortably back into their life. So what has happened as a result of this? Well, I've got data, and I know it's going to be hard to read, so I'll tell you what it says. In fiscal year 2009 was the year that we didn't have anything to do with it. We hadn't redesigned the system. Peers weren't involved. And every year since then, we've increased the number of people served by 32%. We've reduced hospital admissions by 32%. We're averaging we guess that's about 7.3 million in savings. We've reduced involuntary treatment by 32%, about 5 million in savings. We've reduced readmit rates by 26.5%. We've reduced inpatient bed days by 35%, $12 million in savings. What's the difference in this system? The difference is that we have embedded peers and designed it to be extremely peer-oriented in every single way. All right, what do I think the future is going to be for this emerging workforce, for increasing opportunities for peers? I really see that we're going to have increasing normalized roles in the treatment team. How can you have a treatment team without a peer on it? And I think that what we do better than anybody else, and the way that you should think about using us, is that we are better at activation and self-care than just about anybody else, because we've been there. We're a symbol of hope. We can encourage people in a way that no one else can. We can put tools like WRAP, Wellness Recovery Action Plan, like gratitude journaling, that often have been created by consumers, tested by consumers, and now are considered best practices. And we can get those into people's hands in authentic ways. And you can see in the pink box you have some of the data from Judith Hibbard that shows that if we're not activating, we're spending a lot more money and we're spending a lot more time in the system. If we're activated, we're predictive of better healthcare outcomes. You need peers in your system to do this. We are the secret sauce in activation. I think that we're going to have increasingly specialized roles by age, by location. People are working in hospitals and ERs, they're working in health homes, they're working in supportive housing, and I think we're going to continue to see people with comorbidities, people with HIV/AIDS and a behavioral health condition working as peer coaches in that narrow segment, people with diabetes and depression in that narrow segment. I think we're going to be normalized parts of healthcare homes and integrated healthcare teams. Think of the great work Larry Fricks and Dr. Peggy Schwarbeck, consumer leaders, are doing around activation and training. I think we're going to see fee-for-service reimbursement models spread through consumer-operated programs as a part of the network like any other provider. Optum is doing this now. And we'll also be paying for consumer reimbursement of services through established provider organizations. What are some of the issues we need to resolve? I'm running out of time, but there are a bunch of them here. There's still a question about what it means to be a peer. Am I a peer because 20 years ago I had a little trouble with alcohol and never went to treatment? Am I a peer if when I was in high school I was a little bit depressed and took Prozac? I don't know those answers. But as these roles continue to develop, we're going to have to think about them. Peers are being asked to do non-peer work. Is it a peer support job to drive the bus? No. Anybody can drive the bus. Is it great to hire a peer to drive the bus? Sure. But let's not pretend that's a peer job. We've got to deal with licensure credentialing. We're not in every state. Mental health is farther along than addiction recovery. We've got to deal with more Medicaid reimbursement. There are question marks next to the data up there because I see so many different numbers when I go out and look for this data, but this is one source. We've got to, I think it's critically important that we move to fee-for-service. If we're relying on covering peer support through state grants, we're very thankful for those grants, but they are drying up. States don't have the money anymore. We've got to find models where peers can offer these services through a fee-for-service model, and keep those drop-in centers and those consumer-operated services alive. We've got to be cautious and careful about we think about adding peers to systems and staff. There are issues about using peers as cheap labor. That's problematic. There are turf issues out there. Caseworkers think, hey, that's my job. We have to be very clear about what these jobs are. We need to look at career paths. It's not right to keep people at an entry level for the rest of their life. And supervisory issues. No matter how well-intentioned you are, if you've got no training working with peers, you're going to turn them into mini caseworkers or mini social workers because that's what you know. So we've got to be real intentional about that. So to close, I have a story. And this is, I'm a peer who works in managed care. So my closing is a story and data. So kind of a managed care thing. So here we have in Optum a very recent story. I'm calling her Betty Kane. It's obviously not her name. She's been hospitalized 40 times every year for the past 5 years. This is a woman in deep, deep pain. When she's not hospitalized, she has laid herself down in the middle of a busy expressway more than once trying to die. She has got, she's not been able to stay home for more than 2 days in consecutive. So think about that. The best you can do to live in your own house, in your own community, is 2 days in a row for 5 years. Optum is kind of a big company. Okay, we're not going to play numbers here, but it's a really, really, really big company. And Betty is the highest spend in the entire BHO system within Optum. She cycles through every hospital in the state. She has been in every program. They have tried every innovation. And finally, one of the guys came to me and said, Sue, we just are out of ideas. Do you have any? And I asked the question that every single peer in here would ask, right? The first question you're going to ask is, do they have peer support? And the second question you're going to ask is, do they have activation tools that give them hope, like RAP? And the answer was no. So we got Betty a peer, and guess what? She's been home for 8 weeks now. So we are seeing amazing things happen. It doesn't mean she doesn't need her docs, that she doesn't need her meds, but there is something about a peer that opens up the door to activation. And here's the data that we have at Optum for using peers in some of our oldest programs who are reimbursing for peer services. We're seeing a significant decrease in the number of those who use inpatient, a significant decrease in the number of inpatient days, a significant increase in outpatient visits, and a significant decrease in behavioral health costs. And what we love about the significant increase in the cost of outpatient visits is what? We're actually seeing our docs, right? Because we're activated and involved. So when we look at the role of peers in the workforce and where we're going to go, here's my answer. Peers are one factor in the success of the Triple Aim. We are improving the patient experience, we are improving the health of populations, and we are reducing the cost of health care, and that is the emerging role of consumers from my perspective. So here's my executive team. If there's anything that we can do for you, we surely want to. Thank you.
Sue, thank you. That was terrific, and just a great use of evidence and stories and data and cost data as well. Our final speaker for the panel is April Foreman, and April, I believe this is her first time.
Oh, yes.
Yes, oh yes, to this meeting, and she cornered me outside and said, who are all those people? You know, what do they do? And are they going to resonate with what I'm going to present? So she's going to talk to us about technology and using technology in the field for better outcomes. And I think we're on some kind of technology, right?
We're on theme, so let's hope, right?
Okay. All right, so here's April.
Thank you. And let's hope we're going to see. Oh, look, they came up. I'm so excited. So I'm very excited. Oh, and you can't hear me, right, if I don't do this. I'm going to talk from behind a podium. This is so fun for me, so we're going to hope that this goes well. I want to talk to you about Kansas. It seems as if this panel has a movie theme, and I'm going to take you on a journey with me. And this journey, in fact, starts in rural Kansas. Unlike Sue, that's exactly where we're going to be. In 2006, I destroyed my academic career by moving back home. I am the daughter of many generations of farmers and mechanics from rural Kansas and Missouri. People where I'm from don't go to school. Almost all of my extended family lives right where they were born in 2 neighboring counties of rural Kansas and Missouri. And I thought I would go back home. I was very excited to do this because I love where I am from, and I'm sad that as we talk about where we are now, in fact, I am no longer able to be there. But I went back home, having been in academia, where my focus was on training excellent therapists and researchers in the field of psychology to practice as the only psychologist that they had at the time and will ever LP, the only one they'll probably ever have again, in the 4 sickest and poorest counties of rural Kansas, where we had just lost our only psychiatrist due to an accidental fall in a bathtub. True. And we got a couple others, we didn't retain them. And if you ever want my opinions about why you don't retain those folks, I am very shy, but if you approach me just right, I might tell you. So I showed up there very excited to provide the kind of mental health care that the leaders in this room created in my system to aspire to, things I had been trained and taught and reared up in my field to want to do. Imagine my shock and deep pain when I had to practice in the mental health care system that is, and not the one that I aspired to. Imagine how frustrating it was knowing that I worked with people who were paid so little that they were on food stamps. True. Other employees in the community mental health system, serving people with profoundly complicated comorbid mental health disorders, because in a small gene pool things happen. And imagine that my patients often lived hours away with no transportation across the fields of rural Kansas. They did not have running water. They did not have stable housing. But remarkably, and we'll talk about this, they all have cell phones, most of them smartphones and cable, which was new. And I was trying to do the best practice I could do, where I discovered that, and you should know this, I'm sure most of you do, that 1 in 5 people in a community mental health system have borderline personality disorder. I'm like, great, there's an evidence-based therapy for that. We'll just learn DBT and start a DBT clinic. Imagine my surprise when I found out that that diagnosis at that time was not reimbursable and nobody was going to pay for me to have that training. It all happened, we got it done, but that's not this story. So I was deeply disillusioned, and every day was working in a system that was painful and agonist and frustrating. And by 2008, I was in deep despair, and because I'm not a quitter, ask Lee, I'm not a quitter, and so I said, I'm going to hire a coach, and she's going to tell me how to overcome these many challenges to provide this care that I have never envisioned ever providing before. And Lynna Spezia is an amazing person in California, and I would meet over the phone, and she said, listen, you're the only one of you doing this thing you never thought that you would do, but congratulations, you are doing it in the information age, and you are going to use technology to reach out across the country, and you will find the answers you need to do the things you dream of doing. This is an amazing idea. I was pretty intrigued, and she'd sort of restored my faith in my ability to problem solve, but technology is not my friend. And we'll talk more about that in a minute. I didn't have a cell phone at that time, never texted, was not on Facebook. I barely wanted to look at my email. I was one of those people, I was like a holdout on email for a really long time. And that should impress all of you. I think I'm one of the youngest presenters here. Seriously, holdout on email. And I was going to have to do something really frightening for me and extremely difficult in the face of opposition from almost everybody that had respect, good sense, and funding in order to make a difference. Are you ready? So let me tell you actually who I am before we go on. If you want to find me, and where most people want to know me, this is actually me. And if you will find me on the onlines, this is how you'll know it's me. It's these glasses. It turns out this is an incredibly effective thing, but terribly not like most of the headshots we've seen from everybody else. I have a mission, much like all of you, and I want you to know what this is, because if you do not believe me, I want you to find the people who know me, and they will tell you I wake up every day, and I say this to myself multiple times a day to get through the day, and it turns out this changed my life. My mission is to relieve lethal and severe emotional pain, one person, one problem, 1 minute at a time if I have to, and to be more effective than that if I can. And I really wanted to give up. I really wanted to give up and blame everyone that I could possibly blame for me not being able to provide good mental health care under difficult circumstances, and probably wanted to blame some of the people in this room. I won't name names, but I was pretty mad at the system. I was pretty furious. But Lynn suggested that I get some help. I want to talk about change in the world that Lynn was referring to. And I'm very excited to talk about changes in technology. Most of us who are providing mental health care, as you know, in a standard way that was really developed to service wealthy women in sort of a Victorian era, like Austria, like Eastern European, all that kind of things, right? That's what we were supposed to do. We are to be sort of a blank, rather invisible presence where we talk to somebody and as we have this one-on-one, extremely private relationship, they will change. And we'll do this one-on-one with wealthy clients who come to us on schedule after their deep commitment to change. And if they do not change, it is their fault because they have resistance. I know, but every day I still hear this every day. And I work with great people. In the middle of all of this, while I was busy not wanting to have a phone, cell phone adoption rates skyrocketed, and a few years ago, smartphone adoption rates have skyrocketed so that more people on this planet now have a mobile phone than a toothbrush. This is totally true. I looked it up. And I want you to think for just a moment how many times today you handled your toothbrush. Please no one say zero. And how many times today you've touched a smart device that communicates with the rest of the world to do work that's important. I want you to think about how many people you are having a relationship with in real time right now that are not in this room. And you tell me those aren't real relationships that meaningfully impact your life. I dare you, I'll fight you. The world really has changed, and it's changed in really, really meaningful ways. I could talk with you about all the changes in the way that we now provide mental health services, but in fact, you actually know that better than me, like way better, and Sue did a wonderful job. But in fact, how we provide mental health services and to whom we provide mental health services, and how we get paid for mental health services when we get paid for mental health services is really different. And yet, remarkably, despite all of that, a quarter of our population still has a diagnosable mental illness. Over 50%, 50, 60% don't get care. Suicide is still, no matter what we do, and this is really embarrassing because I work with suicidologists, it is still the 10th leading cause of death. If we are not impacting mortality from mental health, if we are not able to reach people, if we are not fiscally sustaining ourselves, and folks, we aren't. I understand we're not supposed to get in this to make a lot of money. I've heard that a lot. But I worked with people who were getting food stamp wages to help the mentally ill folks in my community. That tells us something about what we're doing in terms of sustainability in the system. It's not good. And remarkably, if none of this is working, if we're having people donate their time inappropriately often to serve, and it's still not working, perhaps we should consider changing the way that we view intervention and the way that we view doing things. Change is very hard. It makes us very anxious. I got very anxious about this when Lynn said, I think, Dr. Foreman, you're going to have to change the way that you do things. And the statement I have for you is, oh, if only any of us knew experts in behavioral change. So it turns out in Coffeyville, Kansas, where we killed the Dalton gang and where I lived for several years and practiced about a mile away from the Cherokee Nation, it turns out in Coffeyville, Kansas, if you have a college degree and you want to hang out with other people, there were like 8 of us, and there was no place to go. So I showed up and I asked what the social scene was like, and it turns out there was none. So I had the only house that you could buy in town, which was a ginormous old historic home with lots of parlors, and I like people. So I just said my plan for being successful here is to just have people eat at my house as often as I can. And one of the people who is often at my house is Mr. Tony Wood. He's in the audience here, wave your hand. Mr. Tony Wood knows things about the stuff I did, the technical aspects of it I cannot possibly explain to you, and you should not ask me. So if you have questions, he's the person to go chat with after this presentation, or blame. I don't care what you do. Mr. Tony Wood, after I said, well, this is what this woman Lynn has told me to do, is about technology, and he happened to he owns a technology and consulting business, and he said, this is great, I will help you fix this problem. You're going to need to get an internet presence, a website, and you have to go on Facebook and Twitter. And I proceeded to sweat in my hair. Mr. Tony Wood will tell you that I am literally the worst client he has ever had. We've now collaborated successfully on amazing projects for several years, and when I changed, I have a new little iPhone 6 over there because I was forced to upgrade. I'm always forced to do this. This was only a few weeks ago before the NASCOD conference. I unexpectedly had to upgrade my cell phone ahead of the conference, so I had a new piece of technology. There was a 45-minute screaming fit, I believe, because it turns out that technology is literally the most deregulating thing that I do, and now I do it all the time. And he said, you're going to do this, it will be fine. And I said, I'm really certain that technology is bad, it is probably unethical or illegal, and I will lose my license and never practice again if you have me do this, and it is bad enough what I am doing. And he said, it'll be fine. I can't believe I believed him. He said, no, it'll be fine. He said, you're just going to use Google and you're going to look up what digital ethics are. You're going to take some ethics training, and I'm sure somebody's got it somewhere. He turned out to be completely right. And he said, then you're going to figure out what the most ethical, exceptional people in your field do, and you're just going to do that. And then you said you wanted to have a DBT clinic. So who's the famous person? Like, who are the most famous people in your field? And I said, well, I worship Marsha Linehan. He said, well, then we're just going to use your social media presence to meet Marsha Linehan, get the resources to start a DBT clinic, and you can change your clinic entirely if you want, for no extra funding and with almost little tolerance by your administration. Which all happened, by the way. But first I had another screaming fit. And the reason that we do sort of dates on this, the date for this is October 4th, 2010. So that you understand how rapidly my life has changed. 2010, the direct quote from me, I wrote it on the wine cork from the glass of wine I was drinking to be able to cope with what was being done to me. I said, Mr. Wood, there are no psychologists on Twitter. And he said, he took my computer away from me, and while I was sort of screaming on the floor, he said, yes, there are. You're going to follow 100 of them, and then you're going to go to social media chats where you meet the best experts in your field, because no one's there, because you're going to be an early adopter, whether you want to or not. And you're going to get good at this, which all totally happened. And I have to shout out, I don't know if anybody's watching, I happen to be involved in several really great healthcare and mental health care communities in social media land. And for the folks at the healthcare and social media chat, hashtag HCSM, especially the folks from the Mayo Clinic Social Media Advisory Board who helped me do this. In fact, I was able to do this, and we learned what best practices were. So I recommend, if you want to do this, that you take a digital ethics training. It's a few hours of CEUs, but they'll be amazing. That you develop a social media policy for yourself and for your agency, and that you have it and that you follow it. It's best advice. And then I had to do something really terrible, which Mr. Wood suggested. He said, you really need a media-ready appearance, and right now you look like Mad Madam Mim from Sword in the Stone. You've seen it, right? He says, it turns out, he goes, all psychologists look like that. I don't know why. You all wear long black skirts, you have crazy hair and big scarves. I don't understand. And he said, you'll have to literally throw out everything you own, get things that photograph appropriately, because if you do this right, and I was really convinced we were going to fail, everyone will see you. And you're going to have to now behave as if everyone can see you. Because if you believe passionately that you need things for your patients, and if you believe that you need to do something better, then you will have to suck it up and do things that frighten you, Dr. Foreman, including make yourself look like a decent professional, and be able to communicate eloquently in front of a very large community, most of whom are not mental health professionals, what it is that you need. So we did all of that. It was amazing. And several amazing things came out of that. And if you want to ask me about that, once again, I'm a little shy, but if you corner me, I might talk to you for 10 or 12 days about the things that happened to me. And this is only 4 years. And I want you to understand, we've talked about difficulty in changing and that it's so slow and incremental. This is 4 years, folks. without like any particular backing. It was like, it sort of opened the keys to the kingdom. He said, start blogging and start writing about what you wish you could do for your patients, what you wish you could do for rural Kansas. And I started doing that. And folks from Health Central and Johns Hopkins found me, and we did an amazing project where we were able to use text messaging tools to help patients monitor their mood on a daily basis. And I used this with folks who had borderline personality disorder, who had severe and persistent mental illness, who were some of our most expensive and impaired folks at that time in our clinic. They ended up being the biggest advocates there. I miss them to this day because what we found was that when I provided them much more effective tools using technology, they weren't resistant. Adherence was 91% for months, and we began to have mental health outcomes you've never seen, because it turned out that the technology design of things made such a difference in their experience of how they were being aware of their mood in ways that I could not accomplish by myself without the assistance of technology, that we had results you should not have gotten. And I was the same therapist before and after, but suddenly the folks that I was serving were getting much better. It was so amazing that all of my skeptics sort of began to wonder if maybe I wasn't as crazy as they thought I was. We then, became involved with meeting Marshall Linehan and having a DBT clinic, and sadly, through a series of events I don't like to relate publicly, but I became very, very aware of the disintegration of the mental health care system in the state of Kansas. And the minute that somebody can put that back together, I will go back. But I became very, very aware that I could not stay there and provide care the way that I believed it should be provided to people I really cared about. And I was offered frighteningly embarrassing amounts of money, low amounts of money, to quit doing all of the innovative work that I was doing. So if I was willing to do zero innovation and stop all the projects that I believed in, I could get paid less than half my market value to continue to work in rural Kansas. And I had to make really, really painful decisions to this day that are painful for me about having to leave to go work someplace where it would be supported, which is how I ended up as a suicide prevention coordinator in Baton Rouge, Louisiana, working for Veterans Affairs. By the way, Southeast Louisiana Veterans Healthcare System says hi, sponsored me to come here, and supports me in all of these things, and I want to thank them because it is no less frightening for them than for anyone else. And we began using social media for the Suicide Prevention Social Media Chat, the first sponsored social media chat on Twitter, sponsored by the American Association of Suicidology. We began including multiple stakeholders in that conversation, and we learned a bunch of lessons about not fragilizing or patient-fying people who were participating in conversations. We participated this last week in Text Talk Act. We do live video vlogs, and what I've learned is that we talk to all sorts of new people. But I've also learned that we've done a terrible job of marketing. Much like I had to quit looking like Mad Madam Mim, and I had to talk to other people, I also had to up my game in my messaging. What I can say to you to get you to nod your head and agree with me and make a difference is not the same thing as what I need to say to everybody else. And it turns out that saying things attractively and well thought out way in places where they are matters. And so we used social media to do that. And it's 20 minutes, so I don't have time to tell you all the things that happened. But I can tell you that I have been constantly approached about how we can use social media to do what we've always done. It's not how it works. If you come ask me, I'll tell you. But before I get to sort of the finish of what I think is coming next, I want you to join me. By the way, you have an amazing Twitter presence for this conference. There are multiple requests for most of you providers to please be on Twitter and tweet back. Most of your social media presence is provided by folks who are related to community that I'm largely active in. And I don't think it should be me that drives your presence today. I think that you should be the origin of your messaging. And I'd love for you to come join the rebellion. So if you'll find me on Facebook, if you'll find me on Twitter, if you'll come be my pal, I will totally help you do it. There are a bunch of things coming next. innovations that you haven't thought of yet, but that everyone else has. The end of this story is that most of the innovative work that is happening in suicide prevention and in mental health and media and technology is largely being done by the technology community, most of whom are not mental health professionals and do not think like you. Which is why people come to me, as happened this year with projects where they showed me how using open source platforms like Twitter and public cameras, which are everywhere, they can find people in a geolocated radius. They can say, everybody within 5 miles of this geolocated place who is tweeting about suicide, they can show me pictures of it, and then they can show me video cameras of where they are in distress. Did you know this? It's all public domain, and they can send out interventions if they want, and the folks who are developing this are largely technology and law enforcement folks. Now, when I talk with Ms. Leah Harris about this, who's a pal of mine, she's going to tell you this is frightening because no one's thought of the implications. What I'm going to tell you is that these IT folks found a whole bunch of suicidal people, said hi to them, turned the machine off, and then came and told me about it weeks later. Because none of us were involved in that conversation, because we were so frightened of technology, and because we have not leveraged our wonderful relationship skills to make friends, because the technology scares us, that most of them don't know who we are, how to talk to us, or how to collaborate with us on these projects. When Robin Williams died by suicide, most of us did not have platforms in media that were vibrant enough to immediately deploy messaging about mental health and suicide that would have made a difference around the world, because we were not media ready. The sad news is someone else, very visible, will die related to their mental illness. The opportunity is, when that happens, will we have a media presence that can use that opportunity to possibly save other lives? Those are the things that are coming. I have not talked about conference messaging and how we have set best standards and best practices for talking about the information that we share about how we're going to use Twitter the next year to do CEUs. I have not talked about big data and analysis of social media communities around mental health, or how I can look at trends in mental health based on people's tweets and know where to deploy resources. You'll just have to twist my arm after the presentation. Thank you for your time and for being patient with my nerves. It is a pleasure to meet and know you, and I really appreciate being included.
So April, thank you for a very provocative presentation. At this point, do we have questions? Thank you so much. Okay, this first question is for Sue.
Okay.
Sue, how can we increase the role of peers in providing crisis services and outreach to release police involvement as first responders? Good question.
Well, I think that that's a really great question, and of course that assumes a role where consumers can be on the front line, where we set up systems where they're part of the crisis response team, they're part of the call staff receiving suicide calls, where we've made policy changes within the county, city, state where we're working that allows a peer to be a part of the team and reduces the role of police. So I think it's both a systems issue and a policy issue that we have to go together. I gave you some examples of ways that we're embedding peers, and system change takes a while, policy change takes a while, but some of those things you can do right now. You can expand the role of peers on crisis response teams. You can create warm lines. You can use peers in a way that they're the first people that they are seen when you come in. I know that my sister died by suicide, and every time when she did the brave thing to call and say, I'm in the middle of hurting myself, or I'm going to do this, she would end up in the back of the police car until the last couple times where she stopped. I'm not going through that again. It's horrible. So we have some policy issues and we have some system issues to change.
Thank you, Sue. Peter or April, do you want to add anything to that? Okay. The next question to Peter. You mentioned developing the right kind of workforce pipelines. Where do you see potential to include underrepresented and ethnic clinicians in this approach? There's a lot of parts to this question. What specific strategies are ongoing in Georgia and nationally to tap into the human capital in underrepresented ethnic communities to address workforce shortages broadly and mental health disparities specifically?
So over the next 45 minutes while I answer that question, I did not address the issue of healthcare disparities. I alluded to it in the presentation. Of course, disparities are not unique to Georgia, but they are more pronounced in Georgia, and there is a distinct dissonance between the workforce color, constitution and racial makeup and the racial makeup of Georgians. And so Georgians are about 30% African American by population, and medical students in Georgia are about 12% or up to 15%. And so it is a long, hard effort, and it relates to pipeline activities. And so, for instance, there are summer activities and outreach activities with students in high school to try to draw minority students into training programs and entice them. And that's why I mentioned about the importance of conveying a sense of enthusiasm and optimism about mental health specifically, because these disparities are across healthcare, and we need to be perhaps a little more discerning and perhaps even a little more aggressive in getting people from different race and color into mental health as well. And so we have work to do on that, but there are a bunch of pipeline activities that draw on that. And of course there's also both state and national funding that supports those kind of activities.
Mm-hmm. Could I add just that one of the great things about peer workers is that, you know, peer workers come from the community in which they've been living with these illnesses. They are the neighbors. They reflect the diversity of the community. And so that isn't where we should end, but it surely is one way to begin.
So let me just add on that, Sue. One of the things that we've been trying to identify also at SAMHSA is peer communities that are coming from diverse racial and ethnic populations, that they haven't been actively involved to a certain extent in the peer movement. Can you talk about how the peer movement is beginning to reach out to other diverse racial, ethnic populations to get involved?
Sure. It's funny, you know, I hear that, but I think about going to something like Alternatives, which is the large national conference where peer leaders join, and looks fairly diverse to me when I think about that. But we do know that we have organizations, for example, peer organizations that are specific to different ethnic backgrounds. We also have peer organizations that are emerging that are specific to LGTB and other. We have a group that is groups that are looking at young adult issues, groups that are looking at late life issues. So I love the creativity of the consumer movement, and I'm aware of all those groups popping up as a way to bring forward those issues specific to those particular kinds of cultures and, you know, help create better systems.
Okay, thank you. April, there's a number of questions here for you.
Oh,
no. Could you please say more about the challenges in building a diverse online community, a community that includes consumers, practitioners, providers, etc.?
Absolutely. This is So our suicide prevention social media chat is every week. It's Sunday nights at 9 p.m. #SPSM. Show up if you want to see how it works. It's amazing. We get folks from 6 different continents. We're not really fond of Antarctica, and so we don't include them. And we have folks who are consumers of mental health, folks with lived experience who are advocates. We have nurses, primary care doctors. We have a really involved primary care group. We have folks from law enforcement. We have clinicians, we have academicians, we have data scientists, and these are all folks who regularly show up. If you want to put on a conversation about mental health, if you make it interesting, you think about it, people are really driven to talk about it. They're passionate, and they continue talking long past when the hour is up, and often throughout the week using media. What you must do is we are very full of how we believe things should be, and we say ridiculous things sometimes. Things that, make sense to us and are smart, but sound ridiculous to everybody else. If you let go of that dogma piece, if you don't fragilize people, that was really hard to do. So when my folks, we have a lot of folks with various kinds of mental health challenges who participate in the chat, and the clinicians, when they would very appropriately talk about the challenges they faced that week. Yeah, I had a suicidal thought this week. Here's how I handled it. It's really tough. Boy, this didn't go well with law enforcement, whatever. And they were participating very appropriately. All of the clinicians would find me on Facebook, because I have multiple windows open. I may really fragment my attention. It's probably obvious now. And the clinicians would come to me, and they would be like, do I need to intervene? What is my ethical obligation? Should we discourage them from coming because they're unhinged? And I was like, they're not. And I would say, listen, are they your patient? Have you received any money? Are you practicing in the same state? Have they said that they're at imminent risk? Our policy is, if somebody's really at imminent risk, we will follow the appropriate crisis guidelines. We'll contact someone to help them. And Twitter and Facebook have all sorts of avenues for this, as does the National Suicide Prevention Lifeline. And other than that, you will quit acting like their clinician and start talking to them like somebody who has a shared mission to change the world. And when people started doing that, you would not believe how it raised the level of conversation. When the clinicians quit being anxious, it got better.
Okay, I'm going to stick with you for a minute, April. Can you say more about using trend data from social media to inform program development and policy?
So there are a bunch of data scientists out there who, once again, were not trained in the mental health field and know almost nothing about mental health. You should meet them. They're brilliantly amazing people who work in small buildings with big computers. True. And they are very interested, and there are a bunch of them attacking this problem of suicide risk or the issues of mental illness from various different ways, and they've talked with almost none of you. And so they're looking, and there are various ways that they're going about it. So we have some folks like Ningyu, who is going into networks online and social media with high numbers of folks who have suicidal ideation and thoughts and feelings and risk. And everyone in here knows what Reddit is, right? Good. I like that. You make me feel so much better. So on Reddit, there's, which is sort of the front page of the internet, it's a social media community. There's a whole social media community called our Suicide Watch, subreddit Suicide Watch, that is only for folks who suffer with constant suicidal feelings. And there are a lot of rules about that, and we're very lucky. The moderator of that subreddit is going to be one of our guests. And so not that community, because if Reddit's listening, because they're everywhere, like we're not like spying on you. But on communities like that, where they know lots of folks with suicidality go, they can go monitor those networks and see who the major influencers are, and get a big data sense of how those relationships and communities work. So people with distress, they have communities and networks in real life, face to face, but when it happens digitally, you get data that you can look at in a way you never could before, and so they're going to be using it that way. Mm-hmm. Additionally, we believe that you could use massive platforms like Facebook or Twitter to predict individual risk of suicide, which there are several projects like Chris Poland and the Durkheim Project, or we, just like Google Flu, we might actually be able to identify data that lets us know which communities have higher risk and tell you where you need to be deploying more incentives for healthcare practice or be developing more programming. That is possible today if someone would fund it and develop those relationships with data scientists.
Okay, thank you. Okay, Peter, I want to come back to you and one of these multiple-part questions again. So you ready? Okay. The real crisis in psychiatric person power is in public services, serving people dependent on federal/state funding. How might we grow opportunities for funding the development and deployment of public service psychiatrists? How can we build on the success of other primary care workforce development efforts?
Great. So I think part of that resides in a long and well-established body of work that Georgia has been part of, and that's really state academic collaborations, and that's the opportunity for academic programs that train the workforce to have relationships, in this instance with inpatient public facilities, but with the public mental health system, whether it's inpatient or outpatient, so that people get exposure in their training from early on all the way through their training, and a mature program will develop its own pipeline, so it'll spawn out fellowships, and then it'll spawn out its own lifelong jobs. And then the other value of that is that you will have a workforce that has the core competencies and has the experience and also the interest and draw towards that. One simple example of that, which happens across many states, is the development of forensic psychologists and psychiatrists. That's very hard to do in a correctional setting on its own. And of course, it's not possible to do in an academic center on its own. But when you marry the two together and you put a career path together, and then also you incentivize that for people to either stay in your state or go to rural or underserved areas, then you've developed a pipeline. And so that is a tried and true and well-worn pathway that provides support for the public mental health system. The dilemma is it is from the get-go and always more expensive than other mechanisms of just going out in the street and buying a healthcare professional ready-made. So you're investing in a pipeline that's more expensive, and most public mental systems are strapped and can't afford that, and that's part of the dilemma. Are you treating now, or are you treating into the future? Primary care is another issue and relates to, the blending of primary care training. It relates also to the ability to have residency positions in primary care, which is a very important issue in terms of how the residency programs in America are funded and funneled towards primary care. And so it's a separate but more complicated area also.
Okay, thank you, Peter. I see Lee inching forward. I'm going to try to squeeze in one more question. Sue, what examples are available where peers have been successfully integrated into the reentry planning for individuals with mental illness anticipating release from jails and or prisons? Access to correctional settings for peers with felony convictions being one barrier.
Yeah, there's actually a lot of really creative programs going on where peers come in, they help people they learn about these illnesses that they've been medicated for or not within the system. So they learn about the medications. They learn tools like wellness recovery action planning, other self-care tools. They think about their recovery goals. They create personal goals, and then as they are entering back into the community, they create, there are drop-in centers and there are consumer-operated services where they're welcomed, they're invited to courses, again, a refresher on RAP or a yoga class or something. So again, they begin to have community. There are lots of examples of that out there. You can find several of them in the NREP, the National Registry of Evidence-Based Practices. And, if you want me specifically to hook you up with programs out there, I will just shoot me an email and I'll make an email introduction. I am not afraid of email.
So I want to thank our panelists. We've taken an unusual approach to thinking about developing leaders of tomorrow, from looking at what we need to think about in terms of our public mental health, behavioral health system. What do we need to do with some of the clear challenges in the pipeline strategies? Really, how can we grow an army of folks who are really with lived experience, can be a critical part of the healthcare workforce system. And then April has talked to us about ways to really think about delivering care using and taking advantage of technology, which is growing around the country. So I hope you felt stimulated by the presentations. I want to thank you as the audience in listening to all of this, and very much thank our panelists for their compelling presentations.